Hi, this is Kathy Kosiak, and the presentation for this week will be on the immune system in the older adult. Immune changes with aging results in a decrease in functioning of both B cells and T cells. The primary deficit is in the proliferation of T cells in the body. As you look at this slide, you can see how the immune system declines on so many levels in the older adult, and that, coupled with aging changes and the multiple disease processes and medications that older people take, can alter the immune system and set the stage for a very vulnerable. One of the most important biological changes that occurs with aging is a progressive decrease in immune functioning, or what is called immunosenescence. Neural aging is associated with diminished response by the cell mediated immune system, particularly with the T lymphocytes. T lymphocytes mature in the thymus, which shrinks beginning after adolescence, and by middle age is only about 15% of its maximum size. Cell secretions such as interleukin 2 decline, the ratio of helper T cells, CD4, and cytotoxic T cells, CD8, to other T cells is often reduced. There is a slower response to delayed hypersensitivity reactions, and regulation of the immune system is impaired. As a result, the incidence of infectious diseases, cancer, and autoimmune diseases increases with aging. Hypersensitivity is either an excessive response to antigen stimulation or a normal response that is inappropriate. It usually does not occur on the first exposure to the antigen. Re-exposure to the antigen and initiation of the secondary immune response can stimulate hypersensitive reactions in predisposed individuals. There is a slower response to delayed hypersensitivity reactions in the elderly. If you look at this slide, which is from your text, Tobolsky, it goes through the different types of hypersensitivity reactions. And I'm going to go through these in the next few slides in detail. Type 1 hypersensitivities are immediate and may be life-threatening. Reactions normally occur within 15 to 30 minutes after exposure to an antigen, which is also called an allergen. Some of the more common allergens, which are listed on this slide, include things like seasonal allergies or allergens, grass, pollen, ragweed, mold, mildew, dust, animals, food, drugs, chemicals and products, and insect venom. Some of the acute allergic responses are listed in this slide. Asthma is a common hypersensitivity type 1 problem that often goes undiagnosed in the elderly and doesn't get treated. Asthma increases steadily with age, but it is not well identified in the older person. Symptoms are usually attributed to other problems, such as respiratory issues like COPD or CHF, chronic bronchitis, or other pulmonary disorders. And oftentimes, asthma can be a component of COPD or some of these other illnesses that I just listed. But in the older patient, it often does not get identified as such. If you look at this slide, there are um, several acute allergic responses listed: pruritus or itching, rhinitis or runny nose, rash, redness, fever, urticaria or wheals on the skin generally, but not always, bronchospasm, asthma, laryngeal edema, and the worst reaction that can occur, which is anaphylaxis. This slide shows a response of urticaria or hives, which can not only affect the skin but can also affect the mucous membranes. And if it does affect the upper airway, this can be life threatening. So, in other words, even though you're seeing these hives breaking out on someone's skin and it looks external, it may also be internal. So, it can be significant and absolutely life threatening if the airway begins to swell. It's very important to make sure the allergy history is detailed and always includes the following. And you probably remember how important it was when we did the allergies in the health history that you guys did on each other last semester. We want to make sure we include medications, which should include both prescription as well as over-the-counter meds, herbals, home remedies. Penicillin and latex should be asked of all persons. Foods, environmental allergies, contact agents, and blood products. As a nurse, be vigilant when you're giving a patient a medication for the first time. I remember dispensing lisinopril to one of my vets when I worked at the VA, and he developed acute angioedema of the lips. This can happen to your face, to your throat, to your intestines. It can swell up anywhere. And fortunately, this medication, there are lots of choices for ACE inhibitors. So it was easy to be able to switch medications for him. But the fact that he had this significant reaction was very concerning. So you want to make sure that you watch patients very closely when you're giving them a new medication for the first time. Be alert to any types of drug interactions that might occur as well, especially when many older people might be taking health supplements, herbs, vitamins, and home remedies in doses that are not regulated by the FDA. So we have no idea how much medications or how much of these um, alternative medicines are being taken and what type of a interaction they may have with prescription drugs. Be cautious when your patients are receiving a blood transfusion, as reactions can occur even if the patients have never had a reaction before. So you probably remember doing this in health history last semester when you guys asked each other about allergies and how specific you needed to be in terms of the different categories that you were addressing. So if you look at this slide here, it lists some of the more common allergens that can cause anaphylaxis. Many of us know about peanut allergies these days. Even there have been documented in the literature where someone kissed someone who had just eaten peanuts and had a severe anaphylactic reaction, strawberries, shellfish, eggs. Eggs are really important to make note of because when flu season comes around, it's important to know if someone is allergic to eggs because the flu vaccine is grown in eggs, and so it would be contraindicated to give the flu shot to anyone who has an egg allergy. And blood products that we talked about already, as well as contrast media in which patients may be getting IV contrast dye that they may have had allergies to in the past. My recommendation always is, even though you have your allergy list in your medical record, when you're giving patients a new medication, when you're going to give a blood transfusion to someone, you want to again ask them about their allergies because this might trigger their memory. Anaphylaxis is a medical emergency requiring immediate assessment of the ABCs: airway, breathing, circulation, and initiation of CPR if it's indicated. In the healthcare setting, we're going to give adrenaline or epinephrine, steroids, Benadryl as quickly as we can. In the community, many people carry EpiPens now, and those can be administered if there is a known allergy. If there is not a known allergy, then we need to get that person to a emergency room as soon as possible and initiate CPR if the person is having problems with airway, breathing, or circulation. Type 2 hypersensitivity occurs within minutes or hours of exposure. Examples include blood transfusion reactions, drug reactions, hemolytic anemia, autoimmune thyroiditis, which can result in hyperthyroidism or hypothyroidism. Hypothyroidism is common in older persons, especially in women over 60, and the symptoms are much more subtle. So it can often be difficult to diagnose hypothyroidism. However, knowing that the statistics say that as people age, they often develop problems with their thyroid, older persons should have their thyroid checked routinely. Looking at the slide here, some of the examples: the most severe drug reaction, which is Stevens-Johnson syndrome, is going to be, there's going to be a picture of this in the next slide that I have here. Stay tuned. So this is a slide that shows a picture of the reaction known as Stevens-Johnson syndrome. And when I used to do clinical data sheets, I swear this was the possible adverse reaction for almost every single drug that someone was taking, it seemed. It can be over the entire body. I don't know what the rest of this gentleman looks like, but it sure is diffuse over his back, in the back. Type 3 hypersensitivity is characterized by failure to remove the antigen antibody from the circulation or the tissues. Exposure can be chronic, such as to an environmental antigen or an autoimmune process. For example, glomerular nephritis typically occurs 10 to 14 days after a strep bacterial infection, where the immune complex is deposited in the glomerular capillary wall in the kidney and causes proteinuria, hematuria, hypertension, oliguria, and red cell casts in the urine. This can lead to chronic renal failure. Systemic lupus erythematosus is another example caused by an autoantibody. Signs and symptoms vary since any organ of the body can be involved. Because symptoms of SLE in older people mimic other diseases, diagnosis may be delayed or missed. Late onset of SLE affects women 8 times more often than men and is more common in Caucasians. And some of the other autoimmune diseases that we see listed on here that is rather common in older persons as well is rheumatoid arthritis. Type 4 hypersensitivity is also called delayed sensitivity. Tissue is damaged as a result of a delayed T cell reaction to an antigen. The reaction normally occurs within 1 to 14 days after exposure, although it is slower in older adults. Contact dermatitis from a latex allergy is a common type 4 hypersensitivity. Tuberculin reactions and transplant rejections are other examples. 40% of elderly will not be febrile, they won't have a fever with an infection due to impairment in the temperature regulating center in the brain as we age. There are changes that occur in the hypothalamus. Most elderly have lower body core temperatures. So a temperature of 98.6 may actually be above normal for some elderly persons. So it helps to really know someone's baseline temperature to determine whether or not this is an elevation for this particular individual. It's important then to check temperatures at regular intervals when someone's in the hospital setting, for example, and to note whether they change over time. We want to know what someone's baseline temperature is so that we can determine whether or not there are any changes. Some older persons will be hypothermic with infection. They will have a very low temperature, like 96 or 97. And you wonder what the heck's going on here. You know, this person looks really like they're sick, but they have absolutely, in fact, they have the opposite. And so that can actually be one way in which a person that's older presents. Fever can be further masked by medications like aspirin, Tylenol, steroids, nonsteroidal anti-inflammatory drugs, or other anti-inflammatory agents. Renal failure impairs a febrile response. It's useful to find out if the older adult had chills, which we also call a rigor, R-I-G-O-R. If you hear somebody asking, did he have a rigor? That means, did the person experience chills? And that's significant because in the absence of a temperature, the older person may just have chills. So it's important to find out, did that occur? The older person's heart response to stress decreases. It takes longer for the heart to speed up and more time to return to a normal rate. So you often see the absence of tachycardia with illness. With infection in the older person, white blood cell counts may not become elevated, or they might be just very mildly elevated. Or they might show a shift to the left with no elevation in white blood cells. The shift to the left means that immature white blood cells, band neutrophils and bands, are increasing to help fight infection. So, what's happening is as there is an infection, the body is responding and trying to get out those white blood cells so quickly, but they're immature, so we don't see an elevation of the mature white cells. We just see what's called a shift to the left or an increase in the immature white cells. The challenge in the older adult is the atypical presentation to infection that is the hallmark of infection in younger adults, being fever, chills, tachycardia, an elevated white blood cell count, etc. So you don't see these things in the older person often. Most of the time, I would say you don't. You see what we call non-specific signs and symptoms. And this is, in my opinion, what makes care of the geriatric patient so challenging. In the literature, these nonspecific signs and symptoms that often appear with infection of the older person are called the giants of geriatrics. I like the acronym CLEAR that I found one time in an article many, many years ago that helps to remember what these are. So, if we look at what they each stand for, we'll go through these one by one. The first is cognitive changes or agitation. An abrupt onset of confusion always has an organic cause. The more sudden and severe the change in behavior, the higher the probability it can be restored to baseline through prompt intervention. Studies have shown that many acutely confused elderly have underlying cognitive impairment, and this may not be apparent until brain reserve is challenged with illness or an other acute insult. So when you look at confusion, for those who have dementia, so their baseline is confusion already, they tend to become agitated. And sometimes they might be somnolent or lethargic. In my experience, often the lethargy suggests that the older person is about to become septic. So they are really sick. But oftentimes you see this behavior change of agitation. I remember my mom, here we go again with my dear mom. When she would get an infection, she would get confused. She would say things that didn't make sense, and she was pretty with it. So I generally knew that something was not quite right because you could tell by conversation that she just wasn't making sense about certain things. Loss of bladder control, especially in a patient who is usually continent. They suddenly can't keep their urine in, and this may be certainly with something as common as a urinary tract infection, but it may not be. It may be a different type of infection that is causing instability of the body, and as a result, the patient is rather experiencing loss of bladder control. Eating and nutritional changes. Oftentimes, changes that you see in this category are very subtle. Change in appetite. For example, whenever a CNA tells me that someone is not eating like they usually do, I always see them as a nurse practitioner. It's a very common red flag. when someone says that, they touched their tray this morning, they usually eat everything, they're just picking over their foods or they're just ignoring it. Another common sign along this same category is that the person has a GI upset. They don't feel like eating, and they can't be real specific about it, but their stomach hurts. They just have no appetite, more of a anorexia. Activity or functional changes. You see loss of energy, fatigue. The person, instead of being up and about, stays in bed. They're using their wheelchair instead of their walker to go to the dining room or to get around up and about around the unit. They're not getting dressed. They're staying in their pajamas or they're wearing the same clothes for each day after day. You see the activities of daily living changing. Someone that maybe kept their house very clean and tidy, suddenly doesn't pay attention to that because they just aren't feeling quite right. But again, this is very non-specific. Can't really put your finger on it. Recurrent falls, postural instability. Falls is huge. 9 times out of 10, an older person's fall is a premonition that something is wrong, be it an infection, dehydration, side effect of a medication, a drug interaction, drug toxicity that might be occurring. It is a huge red flag and always should be investigated. Oftentimes you may not see falls occurring yet, but you might see a person becoming unsteady on their feet, easily losing their balance. Sometimes they are experiencing orthostatic hypotension when they go from a lying to a sitting or standing position, which can be from dehydration. And this is kind of a domino effect. The person isn't eating and drinking like they usually did. They have an infection probably on board. They become orthostatic because they're still getting their diuretics, and then they start to fall. So it is a domino effect that can occur and that can really be seen quite classically oftentimes in the older population. The most common infections in the older population are listed on this slide, and they include pneumonia, urinary tract infections, skin infections, and bacteremia. And what we're trying to avoid is that last one. We want to catch, as nurses, we want to catch infections early before they get into the bloodstream. When we're talking about the various infections that older persons are prone to, it's helpful to look at aging changes to each system. That can sometimes help us understand what precipitates these more common infections that older persons experience. We're looking, for example, at changes to the respiratory system. Most everything declines as we age. You can see that just when you look at this slide. Decrease, decrease, decrease. So the chest mobility decreases, and it's really hard sometimes as nurses for us to pick up tachypnea, to know that someone's breathing fast. And that can often be a very early sign of respiratory difficulty and possible pneumonia. There's decreased depths of respirations with aging, so older persons don't take in deep breaths, and they also have a decrease in the number and size of the alveoli. They need to expand their chests on a regular basis to open up the alveoli, or there is stasis of lung secretions at the lower bases of the lungs, which is why It's so important to encourage deep breathing exercises and the use of the incentive spirometer on a regular basis for persons that are older. When you're listening to lung sounds, oftentimes the breath sounds at the bases are very diminished because of this. There's a decrease in the cilia of the lungs and the ciliary action. The cilia are used to cleanse the lung and move particles that are either bacteria or some type of a virus up and out of the respiratory tract. So these are decreased. There's an impairment in the cough mechanism as well as the gag reflex. So older persons frequently have trouble with aspiration as a result. They aren't able to cough, or they cough possibly easily because of dryness, xerostomia, dryness of the mouth, dryness from side effects of many medications. And as they're coughing or choking on food that they might be eating, particles of the food are aspirated and can result in aspiration pneumonia. And certainly, if persons have respiratory illnesses already, they're much more prone to developing any type of respiratory illness, in particular pneumonia. Pneumonia is the leading cause of death in persons older than 65 and older. And the most common is Streptococcus pneumoniae or pneumococcus. In fact, 40 to 60% of pneumonias in the older population are of this type. The combination of pneumonia and influenza actually causes the greatest number of deaths. When older people develop influenza, they generally die from a secondary pneumonia. So it's really important that there is early identification of changes in older persons. And that's why I like that CLEAR acronym, to help us as nurses to determine when someone is possibly showing nonspecific signs and symptoms that may need to be investigated. Because you're not going to often see, in fact, most of the times you don't, see classic signs and symptoms of diseases as we're taught as nurses. You see very atypical signs and symptoms. So aside from early identification of the signs and symptoms of pneumonia, prevention is the best way that we can tackle pneumonia. And one way that we can do that is by educating patients about the vaccinations that are available and when they should be given. The pneumonial vaccine is recommended for all persons aged 65 and older, and the CDC does recommend that this vaccination be repeated for high-risk individuals, those who have COPD, lung disease, any types of other respiratory illnesses, or if the first dose was received before age 60. The annual influenza vaccination is another way that we can help to prevent respiratory illnesses like pneumonia amongst our older patients. There is an excellent patient family teaching guidelines about flu shots, influenza, on page 670 to 671 in your Tobolsky text. And it looks at a lot of questions that older people commonly ask about the flu. And one that I get all the time from patients is that the flu shot gives them the flu, which is a fallacy. The, there is no way that you can give someone the flu with a flu shot because the vaccine is made from a killed, dead flu virus. So you can't possibly get the flu from the flu shot. And what I try to explain to patients often is that it's quite likely that they were already sick with something when they got the flu shot, if in fact they do develop some type of respiratory condition after getting their flu shot. It is a coincidence. It has nothing to do with the flu shot. Certainly, there can be some soreness, redness, swelling at the site where the flu shot is given on the arm, and they can last for a couple of days, but essentially, that is the only side effect that a person would get from a flu shot. And I'm here to tell you, last year I had the bona fide flu. Despite getting the flu shot, I did have influenza type A. It was swabbed, and I have never been so sick in my entire life for weeks. This it had to last for 3 weeks. I mean, not to the extent when it first started, but it is debilitating. And I can only imagine if you are an older person who already has underlying chronic problems, chronic illnesses, in particular respiratory problems, this could really be something that might lead to someone's demise because it is the fact is that the risk of getting the flu is greater than any risk from getting a flu shot. So we really need to talk to our patients about this, of how debilitating it is to get the flu and how often persons do develop pneumonia as a result. Some of the aging changes that are seen in the urinary system include incomplete emptying of the bladder. So there's residual urine that's left behind, which is a perfect media for bacteria to accumulate and multiply. In females, there is a decrease in estrogen, which sets the stage for an increase in urinary tract infections. In males, benign prostatic hypertrophy, or BPH, causes urinary retention. So again, we have urine that's pooling, which is a media for bacteria. There's a decrease in total body water, and so you see chronic hypovolemia in older persons. In addition to this, there is the diminished sense of thirst that is commonly seen in older persons, so they don't drink enough fluids and their urine is concentrated. And overall, decreased number of nephrons, renal blood flow, decrease in creatinine clearance, and glomerular filtration rate, or GFR. And a lot of this last one really has to be taken into consideration when drugs are being dosed. And that includes antibiotics, by the way, for persons who have low creatinine clearance. We need to really make sure that appropriate doses are being prescribed. Urinary tract infections are one of the most common problems in older adults, especially in women. Fecal contamination of the urinary tract with E. coli is the usual cause. And oftentimes, this necessitates some patient education about how to properly wipe oneself when urinating. So, that's something that we as nurses can certainly do with our older patients. Additionally, if someone is having a new onset of diarrhea, be it a male or female. Stool may be getting into the urinary meatus. It might be a patient who is cognitively impaired, and maybe they're wearing an adult incontinence pad, and the diarrhea is getting into the meatus that way. So it's something that certainly needs to be addressed if that's the reason for the E. coli bacteria getting into the urinary tract. The prevalence of urinary bacteria increases with age. It's found in approximately 20% of women over the age of 70, and asymptomatic bacteriuria is extremely common and needs to be differentiated from a symptomatic urinary tract infection. A symptomatic urinary tract infection is treated with antibiotics. Asymptomatic bacteriuria is not treated with antibiotics. So when a culture is sent for a suspected urinary tract infection, the colony count will generally be of 100,000 colony forming units that would suggest a positive urinary tract infection. Certainly, we're always looking at symptoms as in the CLEAR acronym that would suggest a possible infection in our older patients, the mental status changes, falls, declining activities of daily living, which I'm mentioning just a few of those from that the CLEAR acronym. The male population often have urinary tract infections that result is a result of the BPH, or benign prostatic hypertrophy, which can cause urinary retention. Patients who have indwelling catheters certainly are also at high risk for developing urinary tract infections. They often can be taken out if there is no good reason for, or indication for them to be placed to begin with. Patients who have been worked up by a urologist may have problems with urinary retention and require an indwelling Foley catheter. But patients with indwelling Foley catheters often have colonization of organisms. So it's important that patients with indwelling catheters be treated for urinary tract infections only when they are symptomatic. And we look at, again, the same types of signs and symptoms that we've talked about earlier with indwelling Foley catheters, the same CLEAR acronym that we've talked about for our older patients. The thing that I'm really interested in knowing about is that there is some talk about a vaccine for prevention of urinary tract infections in high-risk groups that is currently being investigated, which would be such a welcome addition to especially those who are debilitated and immune compromised in the older population. So the skin is susceptible to injury and tissue breakdown due to the aging changes that we just talked about. Cellulitis is common, and cellulitis essentially is called a skin infection. When a skin infection becomes red, warm, tender, swollen, that is what is known as a cellulitis. And there's a particular type of cellulitis that is called erysipelas, which is a superficial cellulitis from group A strep that usually affects the lower extremities or the face. And there's a picture of it in the next slide that you can look at. Another organism that's common for skin infection is Staph aureus. And skin infections, of course, like other infections, can lead to bacteremia or septic shock. So we want to make sure with these types of infections that we catch them early. There's so often that the infection is at the very beginning stage, but once someone starts to pick at it and give it a secondary bacteria, it can quickly get worse. So it's important to make sure that you don't miss picking up infections in areas of the body where they might be, like, for example, in the abdominal region, on the thighs, in the lower back, on the arm. I've known patients who are pickers. They tend to pick at their skin. It's a nervous habit. And, if you're aware of that, you can certainly be checking these areas for secondary infections on a regular basis. But important when patients are being bathed by patient care technicians, by CNAs, that as nurses, we ask them to report any scratches or open areas that are new so that those can be tracked and have a secondary skin infection, keep a secondary skin infection from developing. So here is a picture of the erysipelas, which is a superficial cellulitis of the skin that we just talked about in the previous slide, caused by strep A, group A streptococcus. The interesting thing about this is, to me at least, is that it's bilateral. So I find that fascinating only because, when cellulitis often occurs, it's unilateral. Not always, but this person may have an other underlying problems that, might have caused this, or it went from one leg to the next. It's hard to know from just looking at it. Other skin infections that we commonly see in older people include herpes zoster or shingles, which is a reactivation of the varicella virus that's become latent and sits in nerve tissue. The distribution for herpes is a dermatomal distribution, so it's unilateral. That's one of the classic signs of herpes zoster, is that it is unilateral. It's on one side of the body, and it's common to see it along the spinal nerves T3 to L2 and cranial nerve 5, or the trigeminal nerve, which is the facial nerve. Herpes zoster can affect the optic nerve in the area of the oculomotor, facial nerves, and that can be one of the most painful courses to overcome. With that type of involvement, there can be resultant paralysis of eye movements or facial movements. Herpes begins with a rash, and sometimes it is absolutely impossible to detect it initially when there's just a very slight area of rash, and then the vesicles appear. It is extremely painful. Herpes zoster is treated with antiviral meds like acyclovir or Veltrex, analgesics, and oftentimes neuropathic meds like Lyrica, Neurontin for short term, because the nerve pain is so intense and so excruciating. I can't even think about it right now because last spring break, I developed, despite having had the shingles vaccine, a what they thought was a post-herpetic neuralgia because I had absolutely no lesions on my thigh, but I have never had such excruciating pain. You can't even touch the area. The pain is so intense. And until I was put on Valtrex along with Lyrica, I thought I was going to lose my mind. You can't sleep, you can't put clothing over it. It is by far, it feels like it's on fire, and there's nothing you can do to alleviate the pain, even though the recommendation is to do oatmeal baths and to, some people think capsaicin helps topically, and not for me. Eat ice packs, tried everything. It is by far one of the most painful things that I think that anybody could ever experience. So, how do you prevent this? Well, the one way that you can is another vaccination that's available. This is a one time zoster vaccine that is recommended for persons 60 years of age or older, and persons who have had shingles can still receive the vaccine to help prevent further occurrences. Oftentimes, getting this vaccine will minimize any further outbreaks. Hopefully, we won't have any outbreaks, but and that's what they think happened to me, is I really didn't have any vesicles. I just had the severe pain and the dermatomal distribution. Oftentimes, after a herpes zoster is totally healed, even years from the time that the person had the outbreak, there can be significant pain that we call post-herpetic neuralgia that can be very intense. It's almost like the outbreak is occurring again, and it might require long-term analgesics or neuropathic meds, again, like Lyrica or Neurontin are commonly prescribed. And for some patients, it's very upsetting, and some will actually get relief from a low dose tricyclic antidepressant that will help with neuropathic pain as well. Some patients really, though, do get significantly depressed and may even have to be put on antidepressants just to help them cope with this pain. The number of cases of tuberculosis is highest in people over 65 years of age, with the exception of those who are infected with HIV. The majority of the cases of tuberculosis are reactivations of dormant infections that were not effectively treated in the past. Older adults are at risk for initial infection of TB due to their compromised immune systems, especially those who are chronically ill, debilitated, live in nursing homes, or have HIV. Due to their compromised immune system, the elderly often have false negative TB tests. And I was really fortunate when I worked at the VA to participate in a study with, actually, it was one of the docs, a resident from the University of Illinois, who took our entire facility to do TB testing after we had an active outbreak of tuberculosis. And one of the things that we, or one of the things her study did was to not only test for tuberculosis, but we also did anergy testing, which is often done along with the TB test on older patients because of their immune compromised state. So we injected patients with one of these two of these three, either Candida, mumps, or tetanus toxoid. And the reason that you use one of these three is that most older adults should have developed antibodies to these antigens, either through vaccination or the disease itself. So, if there is no reaction to the antigen that's given, the mumps, the candida, or the tetanus toxoid, then the patient is, is stated to be anergic, which means that they are immune compromised. They've had no reaction. So a negative TB test then is misleading and can be totally inaccurate. So in those patients, we needed to then do a chest x-ray or collect sputum, which is very difficult to do, to confirm or give a negative diagnosis of tuberculosis. It was a really interesting study. I learned so much about TB when I was doing this. Additionally, as you probably know from having PathoPharm, when we are doing TB tests on older persons, we always do the two-step TB, because those who may not react on the first test, what happens with the first man 2 skin test is you have what's called the booster effect. And so even though the first one's negative, the second one may be responsive because you have triggered the immune system. If it's negative on both of them. So that's partly why we do the two-step. Because of the overuse of antibiotics and increasing levels of frailty in older adults in nursing homes, hospitals, and outpatient clinics, healthcare acquired or nosocomial infections are increasing. A growing number of pathogenic organisms are resistant to one or more antimicrobial drugs, threatening older adults receiving care in a variety of settings. These pathogens include vancomycin-resistant enterococci, VRE, methicillin-resistant Staph aureus, MRSA, which has, in my opinion, been around forever. I can remember this when I was a young nurse, to be honest with you. Clostridium difficile, which is from bacterial overgrowth in the gut, often a result of certain antibiotics or long-term antibiotic use or overuse. ESBL, extended spectrum beta lactamase, and CPE, carbapenemase producing enterobacteriaceae. So the take-home point, I know that we need antibiotics to treat infections, but not all infections are caused by bacteria. Many types of infections are viral, and that's where nurses need to really educate patients and family members about when antibiotics are indicated and when they are not, because if we continue along the lines as in this slide, we're probably going to have more resistant organisms as time goes on. Microorganisms can be introduced into the bloodstream spontaneously as a result of indwelling Foley catheters or from dental, gastrointestinal, genitourinary, or other procedures. Bacteremia may also be a complication of pneumonia, urinary tract infections, infections of the skin and soft tissues, and other infectious processes. The urinary tract is the most common source of bacteremia, followed by the respiratory tract. Perirectal abscesses are frequently missed and can be a source of infection. Once in the bloodstream, microorganisms are disseminated to other organs throughout the body. Endocarditis, especially in those with valvular heart or abnormalities, is a serious complication. As usual, often the older person with an infection that has gone to the bloodstream will become confused, agitated, have mental status changes, and all of the atypical signs and symptoms that we talked about before with the CLEAR acronym. Blood cultures are done to confirm the diagnosis of a bloodstream infection, and immediate antibiotic treatment is necessary and essential. Even before the results, certainly, of the blood culture comes back, we start prophylactic antibiotics, hope that we, have the right bacteria, but if not, then we switch it over to the correct one once the blood cultures are back. Septic shock is a serious complication that develops in 25 to 40% of patients with significant bacteremia. So, our goal as nurses is to prevent the bacteria from getting into the bloodstream, which is why early identification and recognition and treatment is so important, especially in this very vulnerable, immune compromised population of the elderly. Prophylactic antibiotics for dental procedures are done in patients who have underlying heart conditions or valvular problems with their heart or have had a history of endocarditis. We want to avoid any bacteria that occurs during the dental procedure that will then be disseminated into the bloodstream and get attached to the heart valve and cause a endocarditis. People over 50 and older now represent almost a fourth of all people with HIV and AIDS in the United States. In 2014, people over 50 and older accounted for 17% of HIV diagnoses in the United States. And deaths from HIV are rising amongst those aged 55 and older. In 2014, 40% of people aged 55 and over were diagnosed with AIDS. They already had AIDS at the time of their HIV diagnosis. So this is a population, once again, that is being underdiagnosed and underidentified. It's the HIV and AIDS in the older population. Older people in the United States are more likely to be diagnosed with HIV infection late in the course of the disease. Older adults, as we've talked about throughout the presentation today, have weakened immune systems, they have low T cell levels, and their helper T cells, the CD4 cells, are also reduced, which is suspected to therefore shorten the incubation period for HIV. Another reason that HIV is more prevalent in this population is that most older people don't use condoms. They don't think they're at risk for HIV/AIDS. Women can no longer become pregnant, so there's no reason they think for their partner to wear a condom. Many healthcare providers falsely believe that older adults are not sexually active. And AIDS has been seen as a disease that affects younger persons with high risk sexual behavior. So many older people think, this is a younger person's disease. I don't have anything to worry about, not realizing that they're very much at risk with their continued sexual behaviors, which is not a problem as long as they are taking precautions and wearing condoms and not having multiple partners and certainly avoiding IV drug use. Most healthcare providers don't routinely check older persons for HIV/AIDS. So we also have some issues with the healthcare persons, with our healthcare providers that are not even testing older persons. The CDC does recommend routine HIV testing screening for all people ages 13 to 64. Those who are older than 64 should receive HIV testing if they're high risk, such as engaging in unprotected sex with multiple partners and IV drug use. I do have to make one comment right here in terms of, when I talked about healthcare providers, the comments I hear on a regular basis from nurses and phlebotomists as well. And that is when they're starting an IV or drawing blood on an older person, the assumption often is that they don't need to wear gloves because this person is low risk for HIV/AIDS. And we really need to educate each other about the fact that always protection should be something that is at the forefront of your mind when you are working with any patient's body fluids or blood, because you never know what their health risks are or their HIV status. So it's absolutely essential. You can think by looking at someone because of their age, which is very stereotypical, that they are extremely low risk, but there's no way that anyone knows that. And I've seen nurses literally take off their gloves to try to find a vein and keep them off while they are drawing blood, while they're doing Accu-Chek testing, and while they're putting an IV in. And it just makes me shudder. So when we're talking about the identification of HIV/AIDS in the older population, it's important to know that the early symptoms of HIV can be very similar to other chronic illnesses, to dementia, and sometimes attributed to normal aging or the existing of chronic illnesses that the person may have. So oftentimes they are just not taken seriously or not investigated. So early symptoms include general aches and pains, coughing, headache, decreased energy, loss of appetite, weight loss, short-term memory loss, and many older people, and even physicians and other healthcare providers may look at these symptoms and think, well, they go hand in hand with other problems that the person has, other chronic illnesses, or maybe there's some early dementia, or the person themselves may think that these are just normal aging changes. And so there isn't any seriousness taken in looking into this any further. The sorry, antiretroviral therapy, which typically contains at least 3 antiretroviral meds, is used to treat older persons with HIV infection. So the treatment is the same. One consideration that needs to be taken into account, though, is possible drug interactions with the multiple medications that older persons might be taking if they have multiple chronic illnesses that they're taking a lot of medications for. But nonetheless, the prognosis for seniors diagnosed with HIV today is good. So we need to be aware as nurses of the fact that this is something that is more common than may have been thought. And additionally, those persons who have been diagnosed earlier in their lives with HIV/AIDS are living longer due to the antiretroviral therapy that's being given. So we're seeing actually people who have the disease aging in place. This is a taken directly from your book, Nursing Diagnoses and Interventions for Older Patients with HIV Infection, and it's something that you can read at your leisure. I also posted several articles that I found in our library that I thought were applicable to the HIV/AIDS in the older adult. A lot of it is what I've talked about in these last few slides. I tried to pull out the salient points. I think one of the interesting points that I noted is that when you look at some of the aging changes, like the thinning of the skin, for example, and you think of an older female, for example, who's having unprotected sex, and the vagina can tear easily because the skin is very thin, it's very dry, and if someone is HIV positive, that can easily be something that's transmitted just that way, by virtue of not being protected and not being aware, not even thinking about this as a possibility in someone's later years. I almost hate to bring this up, but it was in some of the articles I read, and that is that baby boomers at that point in time were pretty promiscuous, and some remain such. They felt that they may feel that they've made it this far in their lives, so unprotected sex is something that they continue to abide by. But in this day and age, we really need to educate even our older, especially our older patients, because they may be very unaware of the fact that they can contract an HIV. This is just another form that's on your from your book that I think is helpful and looks at specifics for the older person. And remember, as with any infection, HIV being the same, the presentation may be very atypical. So it's something that really should be looked at as a possible problem for that person if there's nothing else that has been identified, especially. And just some further information that I took from your book that I think is helpful. This slide shows selective medications and therapy on the immune system. So, if you want to look at this when you have time, this is again directly from your geriatric text. Some of these medicines, I had to laugh when I looked at this, are really old, and I rarely see them used anymore, like chloramphenicol. Gentamicin isn't even used that often anymore. Streptomycin, very rarely. So I don't know if this is just an old slide or table or needs to be updated. Whatever the case, it does show you the effects on the immune system. And I think some of them you're probably very aware of, in particular corticosteroids, which do cause immunosuppression. The one thing I want to remind you guys of, because even as a nurse practitioner, sometimes you forget this. And one of the more common things that you will see with prednisone, especially someone that's on chronic prednisone therapy, is it causes an elevated white blood cell count. And it's something to be aware of when you're looking at lab values. And your patient, maybe it's an older adult, maybe it's just a middle-aged adult, looks perfectly okay, but they have an elevated white count. Always look at their meds and look to see if they're on steroids. That can be the reason that their white count's up. And it does give you definitely some peace of mind to know that, well, it's more likely from this prednisone than the fact that they have a this is just a list of some other meds that are chemotherapeutic agents, which and ionizing radiation meds that are certainly going to affect the immune system. More common ones: methotrexate, commonly used for even rheumatoid arthritis. And lastly, there are enhancing drugs that you probably do see oftentimes in clinical that are produced by genetic engineering. And there's cells that help to boost white blood cells, and there's medication that helps to boost red blood cells. The white blood cells, there's a couple of drugs that are out there right now, Neulasta and Neupogen, and these are given to patients who are receiving immunosuppressant chemotherapies. And what these drugs do is they stimulate production of neutrophils that are depleted during chemotherapy. So I'm sure that you know that as someone is going through chemotherapy, for many of the drugs, they become neutropenic. Probably have taken care of patients in the hospital who are on neutropenic precautions because their white blood cell count has gotten very low, maybe 1.5, and it's to the point where they can't fight or couldn't fight an infection if they did contract an infection. So these drugs have become lifesavers because patients cannot continue to get their chemotherapy with their white blood cell counts low because they'll drop even further. Their bone marrow is compromised. They're not able to get those white cell counts up. So this really helps to bring that count up. If patients knowingly drop their white cells, these medications can actually be given prior to chemotherapy treatments so that the white blood cell count doesn't drop terribly low. Then we have Aranesp or Epigen, which are drugs that are used to boost RBC or red blood cell production. And these are given to patients with anemia that's due to chronic renal failure or sometimes anemia that is a side effect of chemotherapy, medications, and this stimulates the production of red blood cells, and so the anemia over time is improved. For both of these drugs, I do know for a fact that they are extremely expensive. So when I think about some of the changes that worry about coming down the line in our healthcare system, I hope that what we're hearing in the media, that the sickest and the poorest aren't going to be affected to the point that it looks like they might be. It's very concerning, but these drugs are extremely life-saving. The Aranesp, the Epigen, can save a blood transfusion oftentimes for patients who are significantly anemic, and they just need to have a little bit of a boost to get their anemia or their hemoglobin up a little bit, and this often is what does the trick. So this is the end of my immune system presentation. I hope that it's been helpful in your caring for the older patient who presents with infection very atypically. And so it takes someone with the knowledge of geriatrics, as we've talked about today, to try to figure out what's going on with them. Not looking so much as the typical signs and symptoms that you might see, but those signs that may be more commonplace in older people.